Good morning to all. Now in that UVS Specialty Day, we have got the session 4, testing the test. So we have got a lot of confusion of not only the uveitis specialist, even the general ophthalmologist. How do you interpret the test? Sometimes we order battery of tests and we find that the results come positive or negative. Where we are expecting results positive, it comes negative. And where it's not expecting, suddenly we found the results are positive. So this confusion can be clarified by this well-designed program that is testing the test. So chairperson with me is myself, Jyotirmay Biswas, and Shantanu Mandal is not here. We have moderator Soma Basu from LBPI Hyderabad and Alok Sen from Chitrakoot. So we have got the first talk, and Soma, we can call.
So Dr. Alok Sen from Chitrakoot is going to speak on Mantoux and quantiferon, truths and untruths. I think this is the topic that everyone wants to hear in any uveitis meeting. Go ahead.
Can I have my slides, please? Yeah, thank you. So good morning all, and thank you for this opportunity. The topic that was given to me was Mantoux and IGRA, truths and untruths, and I'll try to do justice with the topic given. I have no financial disclosure for this talk. I'll start with these 3 case scenarios. Case 1, you see multifocal healed scars, and you have an active retinitis patch with some vasculitis. Now this patient has a positive TB gold. The second patient, you can see multifocal lesions in the retina, again retinitis, retinochoroiditis you can say, with dense vitritis, a pan-uveitis-like case, and you have on CT chest, you have what is known as buttery appearance, which is very suggestive of pulmonary TB. And the third case, you have this peripheral granuloma and a positive Mantoux test. So in which of these scenarios you would start ATT? And I think majority and even the chest physicians will agree with the second case that they would put this patient on ATT in spite of a negative Mantoux. While in the case number 3, you would all agree that we would start patients on ATT. And in case number 1, I think many of you would even not advise the patient a Mantoux test. So with this background, ocular TB has always been a challenge for diagnosis, and the definitive diagnosis, of course, is based on isolation of the bug or its DNA from the ocular fluids. However, these tests, microbiological tests, are very difficult and they lack sensitivity because of the possible bacillary nature of the disease as well as the difficulty in sampling ocular tissues. So majority of us, we make a presumptive diagnosis of TB based on the consistent features of ocular TB. This is very important, and on a positive immunological or radiological test. So coming to immunological tests, these are tests which measure the cell-mediated response to TB antigens, and we have 2 tests, Mantoux, which measures the delayed hypersensitivity to the TB antigen, and interferon gamma release assay, as the name itself suggests, it measures the interferon gamma response to sensitized T cells. Now, both these tests are unable to differentiate the latent TB infections from active TB. Of course, latent TB infections now is still another area of contention. Now, Mantoux, as you all know, is one of the oldest tests which is still relevant in clinical practice. We do it daily, almost daily, and it measures the response to intradermal injections of protein, a very crude protein antigen derived from cultures of MTB. Now, the test has to be interpreted based on in which patients we are doing it. So it has, the test positive results have been categorized into different levels. So if you have an immunocompromised patient, you even a test which is 5 millimeter positive is taken as positive. While in patients who are at high risk of developing TB, you have a test which is 10 millimeter is also positive. But in endemic areas like in India, we would rather believe a 15 millimeter or more and duration, which is has to be positive, so that we don't unnecessarily treat a lot of patients with ATT. Now, there are a lot of situations where these tests can be negative because of the technique and interpretation of the test, as well as a lot of biological causes which can lead to a negative outcome in these tests, even if the patient has ocular TB. And of course, these tests are affected by BCG vaccination, although this is very rare. And after 10 years of vaccination, almost none of this can come positive because of vaccination. Now, other non-tubercular microbacterium can also give a positive test or false positive test, TST. So these things have to be kept in mind. Coming to IGRA, there are two types of tests available, and these one measures the gamma release by the sensitized T cells, the other counts the number of sensitized T cells. So these are the two differences, and these are the various antigens that are used for this test. Now, a positive results is as shown on the slide, but the advantage of this test over TST is that it seems to be more specific for Mycobacterium TB, as it is unaffected by BCG or non-Mycobacterium TB, and the patient requires only a single visit. However, the disadvantage is, especially in low-resource countries like India, it can be expensive, you need lab equipments, and it is time and temperature sensitive. Also, there are reports that it could be, the sensitivity could be lower as against TST in TB endemic countries. Now, this is a very important table from a very important article on ocular tuberculosis, which was published way back in 2009 by Professor Amod sir. And what is important when you when you do interpretation of this test is the clinical presentation of the patient. So these tests have to be interpreted in context with what clinical picture is there in the patient. As you can see, that the pre-test probability in an endemic country is almost the same, but the likelihood ratio will depend on what is the clinical presentation. And if you see vasculitis with choroiditis, subregions like choroiditis, or broad-based posterior synechia, and you can see that the likelihood ratio is quite high. And if you have these symptoms, then the post-test probability is very high that the test is positive. So always you have to do interpretation based in context with the clinical presentation and never alone. So to summarize, TST and IGRA most commonly used tests to diagnose ocular tuberculosis. Both the tests have equal sensitivity for diagnosis of latent TB. IGRA probably is more specific than TST. Neither test can differentiate active infections from latent infections. Negative tests, as I had shown in the second case, do not rule out ocular TB, and interpretation of tests should be done in context of prevalence of TB and consistent clinical picture. That is very important. So I thank you, and I thank Professor Amod, who has always been guiding me with all my work. And I think it is only because of me I have this position in the state. Thank you.
We'll take questions at the end. Next topic is the serological testing for infectious uveitis, basic principles. It will be the talk will be given by Padma Malini Mahendradas from Narayan Netrala, Bangalore. Padma.
Thank you, sir. Very good morning to all of you. At the outset, I'd like to thank Dr. Somushila, Dr. Saumavya, and AOS team for inviting me here today to speak on serological testing in uveitis, basic principles with 5 pearls. The serological testing for infectious uveitis can be used as a diagnostic tool to diagnose various infections like bacterial, fungal, viral, and parasitic infections. The principles of testing, it detects the antibodies in the serum. The first question is, what are the methods can be used for testing, antibody testing in infectious uveitis? We have ELISA, commonly used one, that is enzyme-linked immunosorbent assay. The second one is indirect immunofluorescence assay. The third one is Western blot technique. The choose the test depending upon the disease, the sensitivity of the test, the specificity of the test, according to the availability and affordability of the patient, according to specific infection. Next, when to order the serological test in uveitis. It depends upon the stage of the disease and type of the test. The toxoplasmosis is the commonest infectious uveitis across the globe, where we diagnose, in addition to the clinical presentation, serological titer is used to diagnose. There we order both IgM and IgG antibodies. In addition to that, the IgG avidity also can be used in case of pregnancy and other uveitic entities. IgG avidity confirms it's an acute infection. It distinguishes between reactivation and a primary infection. Coming to that, IgG avidity index, if it is low, then it indicates it's a recent infection. If the values are high, then it indicates it's a chronic infection. Next, we get most of the times antibodies are negative due to the epimeral phenomena in case of ocular toxoplasmosis. Invariably, the IgM is negative, the IgG comes positive. Then we divide the patient is immunocompromised or immunocompetent. Suppose if it's immunocompetent, we assess the serological antibodies and IgG is detected, which is increasing. And IgG avidity high level indicates reactivation of a latent infection, or it is low or intermediate level indicates acute infection. The next, we need to understand the disease course before ordering any test. Recently, we had a COVID pandemic, which taught us many lessons. So, this is a graph which showing when we have an exposure to the organisms till we manifest the symptoms. During the time when you have an exposure, whatever the tests we do, it's going to be negative. So then, during the infective phase, the PCR is going to be diagnosis. So after 1 week, you can do either depending upon the source of infection, either the nasopharyngeal swab or bronchoalveolar lavage in a case of a COVID, it's going to be positive. So the antibodies are going to rise only after 1 week. Here you can see the IgM, which usually starts after 1 week and it disappears in 6 weeks. Whereas in IgG, it can persist more than 18 months. So when we see the patient, how many weeks of post-fever or infections we are seeing, and accordingly what we can anticipate. So we have to order that antibody testing. So ELISA-based IgM and IgG are there. If you have increased IgM, we saw clinical worsening. Reinfection, if there is more than 4-fold increase in antibody titers. Most challenging was cross-reactivity with the coronavirus with many organisms. Here we see a case example. A 49-year female presented with here decreased vision. She has erythema multiforme like skin lesions, multifocal retinitis with retinal hemorrhages, suggestive of a post-fever retinitis. Because it's COVID, she had multiple clinical features. These are the investigations we got it. So here, what happened is PCR was negative, but what antibodies for SARS-CoV-2 was positive, dengue is positive, chikungunya is positive. She also had increased D-dimer, another profile which goes more in favor of COVID. She was put on anticoagulant, doxycycline and steroids. When we did the follow-up, when we repeated, most of the antibodies disappeared, whereas SARS-CoV-2 alone is persist in this case. The next comes interpretation of serological testing. We need to be beware of false positive and false negative when we order the test. False positive and false negative occurs due to the cross-reactivity with antibodies against pathogens or due to variations in the antibody levels over time. In these kind of situations, the diagnosis can be confirmed with additional investigations like polymerase chain reaction or intraocular fluid antibody analysis to enhance accuracy of the diagnosis. Here we see a false positive. Here again is a patient presented with blurring of vision since 4 days. She gave history of fever, headache and vomiting, and she also gave history of contact with pet cat which is unwell, and on treatment by the veterinarian, visual acuity was decreased. Here we could see a retinitis lesions in the peripapillary region. We made a diagnosis of post-fever retinitis. When we ordered the test, brucella came positive, so we started the patient on doxycycline and steroids. However, there was persistence of the lesions. By then, we also had history of exposure with cat. Here, Bartonella also have come positive. So we were wondering what it is, but when we repeated, the brucellosis disappeared. So it was false positive in this case, and the patient responded to treatment, not only the doxycycline, and then we have to put the patient on rifampicin. She continued doxycycline, rifampicin, and systemic steroids for a prolonged duration for 2 months. Subsequently, the retinitis lesion is resolved in her case. Next is a case of a false negative. Here, a 45-year male presented with decrease in vision since 3 months. Negative systemic history, whatever we probe the patient. Bilateral multifocal retinitis, suggestive of probably CMV. We did the investigations. Serology for HIV 1 and 2 came negative from our lab. We reconfirmed it. TPHA is negative. ACTAP for PCR came positive for CMV. Because we had a suspicion of CMV infection, we did the CD4 count and HIV viral load. Both came positive in this case. So then again we probed it. Then this patient had diagnosis of AIDS, took ART, then stopped. He did not want to reveal the history, and finally he's in the end stage of the HIV AIDS. So finally we started the patient in addition to the anti-CMV, ART, and as well. So at presentation, HIV 1 and 2 were negative, his CD4 count was reduced, viral load was significant, and CMV copies were also significant. 6 months post-treatment with ART and antiviral, his CD4 count is improved to 410 cells per microliters, and HIV 1 and 2, the repeat ELISA came positive. So HIV 1 and 2 can be false negative in early stage of the disease, in the window period of the infection, or in the late stage of the disease and end stage as seen in our case, or in case of a treatment with intense heart during the acute phase of the disease. So you need important to find out this false negative in HIV infected end stage AIDS. So, and also we have first generation test helps to detect HIV antibodies and also P24 by 18th day of the window period. We also can do PCR from the viral load and other immunoblot assays to confirm the serostatus. The next comes Goldman-Whitmer coefficient. If more than 4 is of diagnosis, additional PCR can be helped to make the diagnosis in case of viral and toxoplasmosis. The next comes the interpretation of serological test in an immunocompromised system. So here again, especially its most challenge comes in a case of a syphilis. We have different algorithms. We order both treponemal as well as non-treponemal tests. This is a table. If both are negative, then there is no infection. Both are positive, then the patient has the infection. If it's non-treponemal is positive, it could be false positive, whereas in case of treponemal can be reactive in a treated syphilis patient. When we have patients with HIV and syphilis, abnormal B cell behavior results in increased antibody protection. The prozone phenomena, because of which we can get false negative results. It's important to dilute the patient's serum to zone equivalence to then perform the test. To summarize, it's important to understand the disease and the stage of the disease, and accordingly we order the serological test. We need to correlate with the clinical condition, and also we have to keep in mind for the false positive and false negative when we order the test. We have to interpret according to the immune status of the patient, and sometimes if the results are not in favor or go with the clinical conditions, we may have to combine with PCR or Goldman-Whitmer coefficient to confirm the infective uveitis. These are my acknowledgements. Thank you for your attention.
Thank you, Dr. Padma. We'll take the questions later. The next speaker is Dr. Shaurya Azad. Dr. Shaurya Azad comes from RP Center, AIMS. Will speak on PCR in uveitis.
Okay, so very good morning to all of you. I'd like to thank AIS organizers for having me in this session. So I am Dr. Shaurya, and I'll be speaking on PCR in uveitis. Is it indispensable? So first, this is the outline of my talk. So first, I would like to talk a bit about how we used to approach a case of uveitis previously, and how these tests have actually added value to it. And then we'll go to the test basically itself, the pros and cons, the indications that we use, the available literature that we have, few cases that we saw in our practice, and then a take-home message. So uveitis is like medicine. So it's like an art of diagnosis, just like combining your history and your symptoms and signs, and then coming up into a pattern, finding some pivot, sort of a key finding, going to a differential, narrowing down your differential, and then you make a diagnosis. That's a probable diagnosis which you can confirm with a test. Now, why I shared this article is that these articles used to come much more earlier when these tests were not there, and we used to basically depend more upon our clinical findings rather than these tests. So this was somewhere published in 1982. This was some 2-3 years before the PCR test came. So putting that into practice, if you see, this was a case which was a 38-year-old male who had come with complaints of defective vision, and he was given oral steroids for some time, and the patient landed up with us who was not responding to oral steroids, and you could see that there was anti-segment inflammation, there was media haze, and there was these retinochoroidal patches, there was arterial involvement, as well as this pigmentary change that was there. So putting the pattern, pivot, and cause diagnosis, confirm sort of art of diagnosis into picture, we had two basic differentials that we had. One was toxo and ARN. All these findings were quite similar in both of them, unless until we saw the other eye, in which there was a pigmented scar, and which was more towards toxo. When we went ahead with serology, it was positive, and then we treated this patient, and the patient showed a good response and improvement. So what if the serology was negative? Was it the wrong diagnosis? Well, I still would have gone with the same diagnosis, but yes, retinitis, when viruses, bacteria, fungi, all these can actually make things a little bit, unclear and sometimes confusing. So we actually presented this case in one of the conferences, and we were asked why we didn't go ahead with PCR. So should we have done a PCR? We could have identified maybe or ruled out a viral etiology. So a lot of patients in which we do not go ahead with tests and we label it as idiopathic may actually land up being some sort of a etiology if we do the PCR. So what exactly is a PCR? PCR is nothing but a molecular test in which we amplify the DNA or the RNA. What is required is a template, primers, enzymes, nucleotides, and buffers. We put it through the steps of denaturation, annealing, and extending, and then we amplify it. How it has evolved now? Well, it's the one which was always there, as ma'am also spoke during the COVID times, the RT-PCR, which we all know, we have all already gone through it. It's basically a qualitative quantitative test in which we can see the disease severity. We went on to multiplex PCR, where we could actually assess for more pathogens, and then to combine both of them, we went to comprehensive, which was first multiplex of trying to find out the pathogen, and then real time to actually amplify them and see for a disease burden. There are more modifications like broad range, strip PCR, and next generation sequencing, in which we can test for more pathogens. So what are the pros and cons? Well, it is a small quantity is required, it's rapid, safe, accurate, and also reproducible. However, the cons are also there. So the positivity is only 50%. There is chance of contamination. There are false positives because of contaminations. There can be false negatives. So if your sequence of an organism which you're trying to look is not there in the test, then it will be for false negative. Even dead organisms can actually come at false positives. And we have to be ready with a narrow differential. We just can't be like we are doing a PCR test and we don't actually have a probable diagnosis. It also requires a specimen of a good quality, so it has to be taken at the right site. It has to be taken at the right time, as ma'am was saying that it has to be taken in the right time period during the infection, right technique, and also transportation. The interpretation also requires that it has to be somewhere connected to the diagnosis, and it is more applicable in viral infections, and contamination is always there, as I said. So the indications that I would say would be that in the case of pan-uveitis, and I'm not talking about those pan-uveitis which are quite clearly, we know the diagnosis like say a Behçet's or a sarcoid or a VKH. Not those, but the ones in which you want to rule out an infectious etiology, maybe an endogenous endophthalmitis or a post-operative endophthalmitis, maybe the patient had undergone a cataract surgery somewhere. So those sort of patients, we can go ahead with a PCR. Even as I said, as I showed the case, that of toxoplasma, retinitis can be confusing. In those cases, we can go ahead. In cases of anterior uveitis, where you want to confirm a viral etiology, you can go ahead with PCR. And some associations like Fuchs, Posner-Schlossman have some associations with viral etiology. In those cases, you can do a PCR. So if you search in PubMed right now, you will have some 1,200 publications, and mostly PCR is utilized for infectious etiologies, and the ones in which it has been done is basically anterior uveitis, and the common organism is viral. So what do we learn? So mostly it is to rule out infectious etiologies. For an Indian scenario, most of the times it has been done for posterior uveitis, like retinitis. The site is more commonly aqueous than vitreous, and etiology, as I said, is both viral toxo. The positivity here is a little different, that it is 50% in cases who are immunocompetent patients, but 85% in immunocompromised. So probably it holds a value there. The treatment change on the basis of PCR is seen anywhere in literature from say 13% to somewhere around about 38% has been said. So it's a little variable. And when you don't have any clinical clues and no suspicion, then the predictive value of this test is not actually good. And sometimes when you just want to confirm it, then in those cases, it is actually beneficial. So now I'll just move on to a few cases. So this was a patient who came up with defective vision and was having a necrotic retinitis in the periphery, focal retinitis in the center, and some hemorrhages over here. So it was an immunocompetent patient, and we were confused how it was. The patient had already received a PST injection elsewhere, and so again, according to the findings, what we thought is probably it's viral because of the fact that there was the peripheral involvement, the hemorrhages, and we started on antivirals, but the response was not there. So then we move ahead with serology, and that was also negative. So then we did a PCR where it came out to be a toxo. When we treated, you could see that there were healing edges and pigmentary changes. Again, another patient. This patient was a patient of ALL, a young patient who had these hemorrhages and focal retinitis over here. We thought it to be CMV. We sent for a PCR. It was negative. We went ahead with the treatment, and it resolved. Another case, in this patient, we can see that there are hemorrhages, there is a prostate branchitis. It's more of that we know that it is a case of CMV. It's an immunocompromised patient, and when we confirm it, it's positive. And you can see it also responds to your treatment. So to summarize, in a setting like ours, in a developing countries where infections are there, it can be done in certain cases. We are not coming to a diagnosis, or whether it's not responding to our treatment. We should not put it for routine testing. It should only be when we have a clinical suspicion. Interpretations should also be interpreted according to the case. It should not be that just because it came positive, now we are labeling it to a specific etiology. Undifferentiated diagnosis, it's not as if we'll just put in some sort of a test and it will come up with a diagnosis. It's not like that. It's more or less the differential that we have, and it might hold some importance in an immunocompromised patient. So atypical presentations are there because of their altered immunity. So there, in those cases, it might still hold importance. So I took this from an article. I don't know the reference. I'm sorry. So idea of performing a diagnosis test is to increase or decrease our suspicion that that patient has a particular disease to the extent that we can make a management decision. So thank you.
Thank you, Dr. Shaurya. And next we have Dr. Soumya Basu from LVTI, and he would be speaking on what to test and how much to believe. When I was preparing for my presentation, I had gone through a lot of his articles on ocular TB, and that had helped me a lot. And see, he has a very huge experience on how to do interpretation of these tests. Over to you, Dr. Basu.
Thank you very much, and thanks AIOC for this opportunity. Now, what I'm going to talk in this short duration is probably what you have heard in the previous 3 talks. I'm probably going to use a different language when expressing the same thoughts. So 5 points. Why do we test in uveitis? Second is, how do lab tests actually influence your diagnosis? What are the examples of using the concept of pre-test probability? I think this is the word that I would want you to take from this talk. And what do you do if there is a high pre-test probability but the tests are negative? And when do we screen for some diagnosis in uveitis? So these are the 5 points that I'll cover in this talk. If you want more details, these are the 2 very good papers that especially all the residents and younger people sitting here should go through. So why do we investigate in uveitis? As you have seen since morning, most of the diagnoses that we make in uveitis are actually clinical diagnosis. And this especially includes most of the retinitis lesions, the viral anterior uveitis, the Fuchs uveitis syndrome. Then in the non-infectious part also, the white dot syndromes. And when I say clinical, it means what you're seeing during your indirect ophthalmoscopy as well as your imaging findings, or VKH, Behçet's, and to an extent even B27 is a clinical diagnosis. So why do we want to investigate in uveitis? There are 2 important reasons, and if you keep these 2 reasons in mind, you can talk to the patient also in a much better way, because many times the patient will come to you and ask that I've been going to so many people and everybody tells me that we don't know why this happens. Or somebody could have said, you know, it's an autoimmune response, allergy, etc., etc. So just tell the patient that there are 2 things I want to rule out. Do you have an infection or not? Second is there a systemic disease that is behind your eye problem? And these are the 2 exact reasons why we do our tests. Of course, there could be other reasons like checking the immune status, the fitness to therapy, and monitoring the treatment response. But these are secondary reasons. So these are 2 questions that I'm presenting to you. One is, if the disease is present, will the test be positive? And the second is, if the test is positive, is the disease present? Now, which of these 2 questions do you think is relevant for you in the clinic? Right? The second one, right? Because the patient is coming to you not with a diagnosis, but with lab reports. And with those lab reports, you want to know if the disease is present or not. So this concept of what will tell you if the disease is present or not, if the test is positive, is called as positive predictive value. And if the test is negative, it's called as negative predictive value. And this is almost the same as the pretest probability, which is the prevalence of a disease before ordering a test. So the positive predictive value is of the test, and the pretest probability is your clinical judgment before you have ordered the test. So this figure basically tells you that in the middle is when you are like 50-50, the test could be, the disease could be present or not present. And on one side are different grades of, you know, when you're not sure if the disease is present, and on the other side, when you're very sure that the disease is present. So when you're very sure, one is very high prevalence of the disease. You know, TB in our country is one example. The ocular signs are, and this is what I want you to focus on, the ocular signs are very suggestive of a given disease. The patient profile, a good example is HIV, or the immune status suggestive of a particular diagnosis. On the other hand, if there's a low prevalence, birdshot is a good example. In India, we do not see birdshot chorioretinopathy. So low prevalence of the disease, the ocular signs are opposing. You see granulomatous uveitis, you're not going to think of B27 or Behçet. Okay? Then you see the patient profile. All of these things will tell you that the pretest probability is low for a given diagnosis. So this is probably the art of practicing uveitis that you should take from this talk. So how do you convert this pretest probability to a post-test probability? And for this we have a statistical concept called as likelihood ratio, which basically combines the values of sensitivity and specificity. And to explain this, I am using this paper which was published in 2009 about the specificity and sensitivity of the quantiferon TB gold test in the diagnosis of ocular TB. And from there I calculated that the likelihood ratio, the positive likelihood ratio was 3.42 for this test for the diagnosis of ocular TB. Now let's keep this 3.42 in mind, okay. Now this is a chart which you are definitely not going to use in your clinic, but this chart has three columns. The middle column is that of the likelihood ratio, and if we put a red dot where our 3.42 is, now on one side we have the pre-test probability and on the other side we have the post-test. And let's look at three different clinical scenarios. One is a patient with a non-granulomatous anterior uveitis, a history of an inflammatory back pain, and there is no history of TB contact. In this patient, for some reason, you advised the quantiferon TB gold test and it came out to be positive. What does it mean? It still means that your post-test probability is just about 10%. So, because your pre-test was so low, just 2%, then these are approximate values. Don't, these are not based on any evidence, but you know that the pre-test is very low. So, with such a low pre-test and with the same positive test, your post-test comes out to be still low, and it's not useful for starting anti-TB therapy in this patient. On the other hand, if the patient has intermediate uveitis, which is relatively more common in TB, but no history of TB contact and the TPH and sarcoid have not been tested, still your pre-test is quite low and the post-test is not more than 60%, not good enough to start your anti-TB therapy. Okay, these are everyday clinical scenarios that you come across. Now the third scenario, you have seen so many cases of serpiginous-like choroiditis being present. Now a patient comes with serpiginous-like choroiditis, there is a history of TB contact, your pre-test probability is very high now for TB, around 80%. Now if you connect the dots, your post-test comes to be around 95%, okay. This is a scenario where you definitely treat the patient with anti-TB therapy. Now all these numbers are approximate, don't go by the numbers, it's only to explain the concept of pre-test and post-test probability to you. Okay. The reverse example, two common tests that we advise all the time in our uveitis clinics, ANA and rheumatoid factor. What is the prevalence of, something wrong with the clock there, okay. So, what is the prevalence of SLE in isolated uveitis when there is no systemic disease? Less than 1%, same with rheumatoid arthritis. Now, if the tests for ANA or rheumatoid arthritis are positive in these patients with isolated uveitis, no other systemic disease, then it really doesn't mean anything because your post-test probability is less than 4.4% for SLE and less than 2.5%. You're not going to treat this patient for either SLE or rheumatoid arthritis. This shows how meaningless it is to test for either of these two in our patients who do not have any systemic SLE or rheumatoid arthritis. Now, what happens, and this again came up many times, you just heard in Dr. AIOC2024's presentation, what happens when you have a very high pre-test probability but your test is negative? You expected it to be positive, but the test is negative. Or you have a very low pre-test probability, non-granulomatous anterior uveitis, but your test is positive, your MON2 is positive. Okay? Then what you do, these concepts are called as false discovery rate or false omission rate, and we come across this all the time in our clinical practice. Okay? You are expecting TB, but your TB tests are negative. Okay? You are expecting B27, but your MON2 or toxo comes out to be positive. When you should not have tested those things, you did test and they turned out to be positive. And these are things that you should be very careful about. When the pre-test probability is either very low or very high, you should be careful about the tests. Okay, I'll not go through this case now, don't have the time. When do we screen? We screen when a given disease can present with any form of uveitis. There is a need for lab tests for the diagnosis. The test is very good, and the treatment is very different from other uveitis entities, and there are only two conditions that fit into all these criteria. These are sarcoid and syphilis. So there is absolutely no other disease for which we should be screening routinely in our uveitis patients. What's the summary? The summary is that the patient is always much more important than the test. The pretest probability depends on the history, clinical signs, and the prevalence of the disease. We should be careful when the pretest probability is either very low or very high and the test is not matching it. And there's a very limited role of screening or workup. Thank you for your attention.
Thank you. With this test of this, what to test and how much to believe, there's a wonderful talk by Shomav Basu. With this, we end the session, talk part of it, and we have got discussion of 12 minutes. 12 minutes discussion. I will first give the opportunity for the audience to ask any questions to any of the speakers. Let's see. Any of you have any questions? For the speakers, Mantoux and quantiferon truth and untruth, serological testing for infectious uveitis, basic principle, PCR in uveitis, is it indispensable? What to test and how much to believe? I have got a question to Alok Sen. Dr. Alok Sen. These are very practical questions. You get Mantoux negative, but you see that tuberculum of the choroid or multifocal choroiditis. How do you convince your chest physician to give antitubercular treatment?
I think that's the greatest challenge that we have. But fortunately, in Chitrakoot, we don't have a physician who will not trust us, because we have only one physician whom we can bulldoze and tell that this is something which we see very frequently, ocular tuberculosis. But yes, it is difficult, and you need to, as uveitis specialist, I'm sorry, I may not be an expert like JB sir, but we still have to educate that ocular TB exists, and there's a very good article by a lack of evidence is not absence of disease. That's what Dr. Basu has written in Frontiers. So we need to convince them and tell them that this is what we see, and these patients do respond even without steroids. So
I keep writing a long letter. I send that my doctor the article where it's seen that TB test is negative, but still it is found to be TB positive, and even call them and talk to them and then try to convince, because sometimes phenotype is so typical for that one, and the test is negative. And there is a paper from AIOC where they have seen the histopathologically TB bacilli, but the Mantoux test is negative in 40% cases. So even in miliary TB, you will be finding the Mantoux test is negative. So you need to talk to the physician to start the anti-TB treatment.
yes, sir, even in
Mic use.
If you follow up this patient where Mantoux is negative and you have a strong evidence of clinical evidence of thing, if you do, for example, 6 weeks or 3 months time, you do Mantoux, there may be conversion of the Mantoux.
booster effect of So the other thing is also true that sometimes even the pulmonary chest physicians, they do put the patient on ATT without evidence of confirmatory TB like acid-fast bacilli on sputum based on just radiological findings. So the converse is also true. They do give ATT without having, so based on the radiology.
You know, we always, in such kind of fora, we always keep on putting the blame on the pulmonologists that, you know, they don't want to believe us. So you have to look at from the other side also. Are we good enough to be believed? Okay, because no one talks about that. Now, I'll again go back to the example of non-granulomatous anterior uveitis. You know, even before checking for B27 in this patient, we test for Mantoux, and the Mantoux turns out to be positive. You know, and we send the patient to the pulmonologist to start anti-TB therapy. We are ourselves, you know, making grounds for the pulmonologist to lose trust on us. So it works both ways, and it's important that in this forum we discuss that part as well. Okay. The other thing about the negative tests, just remember that the MON2 or the quantiferon TB Gold test, they just represent a memory immune response. And this can be extremely variable between people. If there are 50 people sitting here, all of whom have been exposed to TB, and we do the MON2 test and the quantiferon test in all those 50 people, they will show varied responses even amongst healthy people, leave alone the immune compromised, etc. Okay. So the clinical diagnosis, the pre-test probability of your disease based on what has been published for a given, be it TB, toxoplasma, anything, that is way more important than the tests that we do in our patients.
Okay. From the MON2, we'll go to that serological test. I like to ask Padma that one question: do you repeat the ELISA for the toxo test after the patient's choroiditis has resolved, retinochoroiditis has resolved? Yeah, I just wanted to hear that. The routine toxoplasma test, you don't need to. Once it's positive, it remains positive. Huh? Just take the mic, please. Please take the mic. This mic.
Coming to the toxoplasmosis serology, we make it at the time of presentations. I don't do the follow-up. If the patient is responding to treatment, I go by the clinical judgment.
Correct.
So we have several senior uveitis experts sitting here, and let's look at two people from two different parts of the world, Professor McCluskey and Dr. Vishali. It's a very simple question which I'm sure many of the general ophthalmologists sitting here will have for you. It is, if a patient of uveitis, any uveitis, and I'm using a very broad term here, comes to you, how liberal you are in ordering the number of tests that you do in a given patient of uveitis.
Floating mic.
I'm sorry, there is no floating mic.
Yeah. Floating mic.
Do you want? Yeah. So where I'm basically all our investigations, serology, anything is based on our clinical assessment. So basically, the most important part of sorting out any uveitis patient is the history, a thorough, careful exam of both eyes, and a careful directed systems review. We often you start taking the history, start examining the patient, that will then direct you back to some more questions. Probably the only routine test in my clinic that we do on pretty much every patient, because we're a tertiary referral uveitis service, is syphilis serology and a chest x-ray. Pretty much everything else is guided by the clinical assessment.
Thank you very much. So we just heard from Professor McCluskey that there are just two tests that he does routinely in all his patients: the syphilis serology and chest x-ray. Your take, Dr.
Yes,
Vishali.
I agree. We do syphilis serology simply because we can get confused. But other than that, I don't get chest ray also from everybody. Only if the phenotype is suggestive of TB, only then I order. And I'm very happy to listen to your talks, because I'm sick of replying letters after letters by a premier institute in this country that everybody is Montius positive, so will you treat everybody? So, courts never said that. The basic is you first have to see whether that test is required, then you do that test, and if it comes positive, you treat it. If the academia of our country is not able to understand the basic question, I think Soumya brought about a very important aspect, both of you, that we need to understand what are we ordering. Thank you for bringing that up.
Thank you.
I want to ask a question to Shaurya, that how often you have changed your practice pattern, like your treatment regimen, after getting the PCR results?
So, sir, as you saw in my presentation, I hardly have ever used, I generally don't use PCR in my routine investigations, or even for that matter, my clinical judgment, or probably, if not that, then at least response to treatment is what guides. So I hardly ever use PCR. Maybe yes, in an immunocompromised patient where the whole presentation is very altered and you might have given treatment, it's not working out, and there you might try. Otherwise, I don't think so that we do a routinely PCR, that often we do PCR at all.
So in case of viral retinitis, still you
No.
treat as a
As a
clinically.
clinical picture that is there, as I said, that if it is central or peripheral, whether hemorrhages are there, whether it's necrotic, all those clinical findings, immunocompromised, immunocompetent, all that will lead to a diagnosis, and that is probably maybe confirmed, if not anything, rather than it actually throwing up a diagnosis by itself.
Do you feel there is a difference between the nested and real-time PCR, which one you order?
Frankly speaking, I am not an authority in this. I've not done a lot of tests, so I'll not be able to tell on this. So, because we don't routinely give.
Probably the real-time PCR would be better with the copy number.
The copy number, yes, for the disease burden, it is better. But yes, for looking at more number of pathogens, it is better that you do a nested.
You give the final comments. Any other questions?
Yeah, just a quick, because I think, sir, you
Please.
want,
May I ask you?
yeah, please, go
So
ahead.
if you are very much suspicious about tuberculous choroiditis, but all tests are negative, and you cannot convince your physician to start on ATD. So, so what do you do? Is there any rationality of prescribing clarithromycin in those cases?
No, I think again, just like you shouldn't test everything, you shouldn't also treat everything. We should, we should go by our suspicion, and like we have just discussed, these tests can be negative in people who have real TB. The pulmonary TB, other extrapulmonary TB, you can have negative. In extrapulmonary TB, up to 30% can have negative quantiferon tests, and these are microbiologically proven extrapulmonary TB. So, if one physician doesn't agree, try to explain that person, and then go to another physician. But before that, you should be convinced yourself that whatever you are trying, because any other person will pick it up that you are not convinced yourself. So you should be convinced yourself before going to the next person. That is the main thing.
Sir, is there any role of vitreous biopsy in sending for CB-NAT?
CB-NAT has relatively low sensitivity for in vitreous. I think we have very good studies from PGI which shows that conventional PCR has better sensitivity for with the vitreous samples. I think we'll.
So we have passed the time limit, and we like to thank all the my chairperson, moderators, Shoma Boshu, Alok Sen, and the speakers who has given a good overview in a short span of time about the testing, the test, various topics, and we have got a good discussion. With this, I like to thank the AIOC for giving us the opportunity to have the Uveitis subspecialty day. We didn't have this type of day earlier, and Uveitis is becoming well recognized, and it's a significant amount of patients lose vision or become blind even due to the uveitis, and the proper test, proper diagnosis, and proper management is very crucial. And this type of subspecialty day with this subspecialty day with in-depth discussion will make the things clear.
Thank you very much.
Thank you very much. We'll take a group photo.